Hello, my name's Stephen Jurd. I'm speaking to you today from the Sydney Retreat. Here at the Sydney Retreat, I've developed 4 talks that talk about the basic biology of addiction. I call them the doctor's opinion because they align to and update to 2025 the notion of addiction as a disease. Way back in the 1930s, Dr. William Duncan Silkworth treated a lot of the early AA members, and he impressed upon them his observation that there seemed to be something physical as well as something mental happening in people who have addiction. And his theory at the time was that there was an allergy to alcohol. At this point, when people say allergy, what? I don't come out in hives when I drink. It's like there's one celebrity who was famous for ending up in the orange jumpsuits when he was subsequently interviewed, when he got sober and was subsequently interviewed on the talk show promoting the next movie. He said, "I've got an allergy to alcohol. When I drink, I break out in handcuffs." So don't be bugged by that word allergy. That word helped me as a doctor to think, what actually is it? What's really going on with inside the body when the alcohol or drugs hits the body? What's the reaction? Early in med school, you do chemistry, and you think about chemical reactions and how the ester plus the alkali met together and you create the soap or whatever. How does that happen? And in the same way, every prescription of every drug in every individual represents an experiment because different people respond differently to different drugs. As doctors, we study the pharmacology very carefully, and so we were able to, with pretty good precision, predict what's going to happen when this drug goes to that person, but we're all aware of idiosyncratic reactions. Some people react differently to the drug. Here at the Sydney Retreat, I encourage our guests to become citizen scientists and to review their observations. And one of the observations I take them to is, it's Saturday night, it's late, the restaurant's been really busy, it's been a busy, boozy night in this restaurant and they want you to leave. They slap the bill down on the table and say, "Thank you for coming to our restaurant tonight," basically time to move out. And then as you wend your way out through the tables, it's been so busy they haven't cleaned up yet, you glance left and right and you see on the table half empty glasses, even half full bottles. And for committed drinkers, it's hard to imagine paying for it, pouring it out, drinking half of it and saying, "I don't want any more." And so in that way, some of the guests are able to understand that perhaps their physical reaction to alcohol is different to other people's physical reaction to alcohol. There are lots of people out there who can start a drink and say, "No, I don't want to finish it. No, thank you. I don't want any more." That's what Silkworth was trying to describe when he talked about the allergy, the internal physical drive to drink on. Where does that come from? In the course of my career, so back in the late 70s and the early 80s when I was training in psychiatry, there wasn't as much known about the brain as there is now. And what's been understood and discovered since then is the reward pathway. And the reward pathway is deep down inside the brain, down here, through here, at the very base of the brain, the old part of the brain. In one of these talks later, I will talk about the evolutionary significance of that part of the brain and the way it relates to the rest of the brain. But the reward pathway evolved as a primitive decision-making system for reptiles. So it's like 100 million or more years old, but it's been retained in mammal brains and in primate brains and in ape brains and in our brains. And so we have this primitive decision-making system that goes off, that goes, pow, wow, it's something amazing just happened. You know, I just filled my mouth full of mango and it's like, yes, that tasted really good. I want that. At that point, the dopamine's flowing. A lot of other people who talk about addiction, they talk about dopamine and they focus on the dopamine and they talk about the substance. All that dopamine does is it gets released from a little bulb at the end of a nerve. Out comes the dopamine and it gets caught by the receptor on the other side. So when I eat a mango, when I smell a mango, I remember, and there's a little blast of dopamine that comes out, but when I really have it in my mouth, then boom, 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 the dopamine flies. So why is this so relevant? Because it's that very part of the brain where addiction lives. It's a primitive decision-making system that sets up the value of each experience. So I love apples, but I love mangoes better. And how is that determined? The amount of dopamine that flows and the encoding of that in other parts of the brain. So we've got a fruit platter here, and I know, oh, yes, I do like that apple, and oh, yeah, I don't mind the apricot too, and a good peach, oh, peach can be good, sometimes not so good, sometimes too crunchy, don't like, whatever. And there's the mango, and I like it every time. So, and all of my preferences are encoded in my brain. Now, all drugs worthy of the name, all drugs with a street value, they all make the dopamine flow down the reward pathway. Artificially. They turn it on. So when I've got a mouthful of mango, the dopamine's flowing and it's like, yeah, it's the mango in the mouth. That's what's good. But when you inject a substance into your body that makes the dopamine flow, your brain goes, I like whatever it is that's happening now. So substances of abuse, anything that's good to snort, to drink, to shoot up, to pop, that makes the dopamine flow and makes a human being think, hey, something really good just happened. Something amazing just happened. And so this explains why decision-making is distorted in addiction, why things that we believe are important, we believe these things are important, we know these things are important, but we don't act like they're important. We take a substance, we artificially stimulate the reward pathway, and we trick our reward pathway into thinking that something important's just happened. And that alters our value. All of a sudden, mango's not peak experience anymore. Maybe even the wife, the children, maybe even love itself isn't a peak experience anymore. Because what happens is pharmacology overcomes physiology. Early in medicine, I studied physiology. Physiology is the normal functioning of the body. And so we learned how, when I move my arm, send a message from my brain to my arm, and the acetylcholine is released and it makes the muscle contract. And so my arm moves. And that's normal functioning. But the point of pharmacology, medicine prescribed by a doctor or obtained at a pharmacy, the point of that is to overcome the physiology. So if, for example, you've been leading a very stressed life for years and you're pumped up and your heart pumps harder and harder and you never settle down, you can end up with high blood pressure. You go to the doctor, he goes, pump, 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 and how good's your blood pressure? And it's high. Oh, he says, write a script. Artificially, it hits the receptors, sometimes in your neck, in your carotid artery, sometimes in your heart, sometimes in your kidney, turns down your blood pressure. And so the artificial chemicals, the pharmacology, It's purpose designed to overcome the normal bodily function. And that's what's happening in addiction. What happens, if we go back to our incoming message, the spike comes down the nerve and then disrupts the vesicles, the little packets of dopamine that are stuck at the end of the nerve, and that disrupts the surface and they spit out dopamine and it catches it. So something good's happened. And what happens when you do pharmacology, you get half a belly full of beer and you snort a whole bunch of white powder at the same time, and then, whoa, your system goes into overdrive and it releases all the dopamine. And so your receptor's going, and they're all full, and it's full to the max. And many people remember that first time when they were completely overloaded. And a lot of their subsequent addiction is chasing that first high that's never as good again, because the body adapts. The body's gone, you filled all my receptors. I always need some spare. So the receptors multiply. And so this is how tolerance occurs, how the same dose has less effect, or you need a higher dose to get the same effect. And that's how it happens. You get more and more and more receptors, and so it's your body doesn't want to fill up all the receptors. It needs a bit of space. What if something extra good happens? Some extra good needs to be encoded, but all my receptors are full up. Okay, it's not working. So the body responds and creates extra receptors, which means that eventually life gets a bit boring. When you've been drowning your reward pathway in dopamine after dopamine after dopamine, and it's not filling up like it used to, then when you're not doing that, then life can be pretty boring. And the straighty 180s, you know, the people who live on Straight Street, they're pretty boring too, and you don't want to hang out with them anymore. So that's the first thing. Physiology overcoming pharmacology in the reward pathway. Now, like I said, a lot of people talk about dopamine. I prefer to talk about the reward pathway because it is a physical nuts and bolts part of the brain. It's not just a neurotransmitter that comes and goes and you can manage like that. No, this is a physical part of the brain in there, down the base of the brain, that is in all human beings, and particularly susceptible human beings, when that part is stimulated artificially, will lose their balance and the chemistry will overcome and the tolerance happens and so on. Now, I jumped forward a little bit by talking about mixing drugs. And in particular, I talked about mixing alcohol with cocaine. And I understand that happens a lot now. Again, back in my early days of practice in the addiction area, and even before that when I was training, doctors thought, and the diagnostic manuals separated out alcohol dependence from other substance dependence, and they didn't try to unify it as addiction. And there were even theories to say that, some people like sedatives because of some particular nature within their body, and others liked stimulants and so on. But now it's common that we talk about party drugs. And party drugs usually means just about everything. So that, you take a drug that makes you confused but still stimulates you, like MDMA, ecstasy or something like that. But you also take alcohol, which is a sedative, and you also use a cocaine, which is a stimulant. Now, you'd think if you're paying good money for good booze and good money for good street drugs, why would you use drugs that were opposite and therefore cancelled out? And the answer is there in the reward pathway, because that's not the case. They do not cancel each other out. In terms of consciousness, they cancel each other out. In the reticular activating system, even further down into the old brain, the part of the brain that says, wake up, go to sleep. The cocaine says, wake up, and the alcohol says, go to sleep, and they have a little battle there. But just a little bit higher up in the reward pathway, they both increase the flow of dopamine. And for me to try to explain it to people with even less medical training than I've got, what I say is that the stimulants put their foot squarely on the accelerator. So here in the cell body, down the nerve, they go, shh, let's go. Let's go. I am cocaine, I am amphetamine, I am ice, get going. Lots of dopamine, let's flow. So there's that happening. How then do opiates or alcohol combine with that? Why do people mix opiates, heroin and cocaine and shoot them up in the same syringe as a speedball, they used to call it? And so how does that happen? Because there are these things called interneurons. On the reward pathway, along the line of the reward pathway, there's interneurons that come down this way, up this way, all around, and they modify the reactivity of that pathway. So they are like the brakes. So the stimulants put their foot on the accelerator, the sedatives damage the brakes. And by damaging the brakes, again, you get extra flow of dopamine. So many people find it highly rewarding to just take a sedative or to just take an opiate. Many people give up their lives to opiates, give up their lives to alcohol. And that's brought about merely by damaging the brakes, and that still increases the flow of dopamine down to those receptors that are multiplying and that are crying out for more. We want more. We remember how good it felt. Like you remember the first time you had a really good Thai meal, the first time you had beef mussaman curry, I believe is one of the most popular dishes in the world, because it explodes flavour all through your mouth, and the combination of sweet and sugary and fatty all comes together, and it really makes the dopamine flow in the reward pathway. In the same way, drugs do that, but artificially, and so at an even higher level. The reward pathway explains how different drugs can produce the same result. So drugs as different as heroin and cocaine do produce the same addiction because they operate on the same site and by different mechanisms still increase the dopamine flow. So that was a revelation to me, because it helped me to understand the unification, the unity of addiction, how it is all the same. It doesn't matter whether you're in a pub knocking back schooners or you're, down the road in a shooting gallery shooting up some drug. At a technical pharmacological level, you're doing the same thing. You're increasing the flow of dopamine. So that explains the unification of addiction, why it's all one thing. Back in my early career, they used to separate the addicts and the alcoholics. It used to be easier to do then. We had a less of a drug-soaked society, and there were lots of people who had quite severe drinking problems who didn't take any drugs at all. And oftentimes they thought of themselves as much better and not lawbreakers like those addicts. But now we know that it's all the same, and a large proportion of the people with drinking problems use drugs, legal or illegal as well. And likewise, we know that the people who use substances, who use illegal substances, oftentimes when they run out, when they can't get their stuff, when they don't have enough money, they will seek solace in alcohol because it does the same thing. It makes the dopamine flow. And so this explains the unification of addiction. It explains how some people mix drugs even though they're of apparently opposite effect. They are still mixed because they result in the same thing, increased flow of dopamine in the reward pathway, into this tiny little shell, a 2 millimetre thick shell around the nucleus accumbens deep in the brain. And that's where the action happens. It's not the dopamine, it's the dopamine hitting those cells in that reward pathway that says, yes, this is really good. I don't care what anybody else says. I've had the experience. I really like it. Unification, pharmacology defeats physiology, mixing drugs. The other thing that it therefore explains, and I've almost made reference to it there just recently, is switching drugs. How in the course of addiction, it's not uncommon for people to start with drinking too much or smoking cannabis, and then to go from that to taking a few pills of oxycodone or something like that, and to go from that to using heroin, and to go from that to using other classes of drugs, like trying to balance off their benzodiazepines with their cocaine or ice or other stimulants. And so the reward pathway explains all of that. So this is what Dr. Silkworth was trying to say, that there is a part of the brain that is so old and primitive that it's outside of awareness, it's outside of consciousness, it drives our desire, and it explains these various complex things about addiction that lead you to the conclusion that every human being is at risk for addiction, because we've all got this reward pathway. And if it's completely overloaded, well, then anybody can get addicted. And that is true. However, the question I'm usually asked is, well, hang on, but I hung out with other people who used the same substances, probably about the same rate as I did too, and they just cleaned up their act and off they went, and, they're out in the suburbs, doing the 9 to 5 thing. They haven't lost their lives to it. What's going on? What's the difference there? And that leads to the next talk in this series of 4 talks. And the next talk is about genetics. You'd expect that if something does have a physical basis, then there could just be genetic differences. And that's what studies have found, and we'll talk about that in the next talk. Thank you very much.